Welcome to the Triage and Decontamination module for Pediatric Surge. I'm Dr. Paula Kocken, a pediatric emergency medicine physician at Children's Minnesota.
And I'm Ross Chavez, paramedic and assistant chief of Hennepin Emergency Medical Services.
This module was designed to help healthcare providers think of the unique issues that may arise when triaging or decontaminating a large number of pediatric patients. After viewing this module, the participant should be able to list the unique characteristics children bring to triage after a mass casualty incident. You should be able to review the standard triage and the Jumpstart triage strategy for children. Finally, you will be aware of the unique needs children have when decontamination is indicated. Triage is defined as the assignment of degrees of urgency to wounded or ill patients, which ranks the patients in the order of their need to be treated. It can be a very difficult task. We have learned from the recent mass shootings in Colorado, Orlando, and Las Vegas that the triage of most patients may not take place at the scene or in the field. Patients often end up being transported to the hospital by family cards, Good Samaritans, or police, bypassing the EMS triage system. Therefore, emergency department personnel will have to determine who needs treatment first, who can wait, and where efforts for stabilization should be focused. Even if patients have been triaged by EMS, secondary triage in the emergency department should be performed. When there is an overwhelming number of patients, the goal of triage is to do the most good for the most patients. You must assign a degree of urgency to wounded or ill patients, often quickly. A universal color system is utilized to sort patients. A patient is given a green rating when they are ambulatory with minor injuries. These are the walking wounded, and a delay in their care should not affect their outcome. Patients rated yellow need treatment, but the initial assessment, they are not emergent and can wait a short time to be treated. Patients that need immediate treatment or they may die should be given the color red. These patients may need a life-saving procedure like needling the chest to relieve pressure from a tension pneumothorax. Patients who are dead are given a black tag and should be respectively placed in a secure area. Remember, triage is a dynamic situation. Just because a patient is yellow when they come through the ED doors doesn't mean they will stay that condition. A yellow patient whose treatment is too delayed may progress to a red status or even black. This is why it is so important to always reassess and reevaluate your patients. Here is an example of a common triage tag. Every hospital should have similar tags in their disaster kits. Emergency department personnel should be familiar with them and be able to use them as needed. Now we will discuss the specific differences between triaging children and adults. First, how children respond to a disaster can be very different from how adults respond. Children may not follow instructions. They may hide from rescuers or wander away from the scene. Some children may even run to a disaster, thus putting themselves in more danger. They easily wander away if there is something more interesting to see. Children's vital signs vary with age and environmental conditions. They are more likely to have a respiratory arrest than adults. Therefore, if they are apneic, it is likely due to an airway issue and not cardiac issues. As a responder, you can improve a child's chance of survival by opening their airway and giving rescue breaths when they are apneic or unresponsive.
We will now discuss START Triage, a system for rapid triage of patients. As the acronym states, S is for simple, T for triage, and R for rapid, T for treatment. Simple, triage, and rapid treatment. It is the major strategy for triaging patients in the United States during a mass casualty incident, or MCI. It utilizes the 4 color classifications we talked about earlier. The key is to spend 30 seconds or less with each victim and move on to the next. The materials for START Triage can be found at this website. This algorithm is for all patients and does not take into account the unique difference between pediatric and adult physiology. Jumpstart Triage was created by Dr. Lou Romig in an attempt to adequately treat all victims in an MCI, including children, not just adults. Jumpstart integrates some of these differences into this triage mode. It is designed to include patients ages 1 to 8 years old in the triage and can work moderately well with infants. With the in-between ages 9 to 14, if they look like an adult, treat them as an adult. The materials for Jumpstart Triage can be found at this website. Jumpstart works the same as START, so providers do not need to learn a new plan. Only 30 seconds should be spent on each patient, and a team of caregivers should be available to treat the victims designated as red. Here's the Jumpstart algorithm at a glance. We will now break it down into its components. First, you need to identify your ambulatory or green patients. This is easily done by shouting out, "If anyone can walk, move over here," to a designated area for secondary triage. Children with special health care needs who are chronically non-ambulatory and minimally injured can also fit into the green designation and can go in wheelchairs. Remember, if there are numerous children, you will need monitors and diversions for those children who are in the green triage area. Monitors can be other providers at the scene or adult ambulatory or green victims themselves. If the patient is not ambulatory and is breathing, the next step is assessing the respiratory rate. If the child is apneic or having irregular breathing, then the assessor should reposition the airway. If the repositioning results in spontaneous breathing, then the patient is tagged red or immediate and assigned to a caregiver. If, after repositioning the airway, there is no spontaneous breathing, a peripheral pulse should be checked. If there is no pulse, then the patient is designated black or deceased, and the assessor should move to the next victim. If a pulse is present and the patient is apneic, give 5 rescue breaths. If apnea persists, mark the patient as black or expectant and move to the next victim. If the patient resumes breathing, then the patient should be tagged red or immediate and assigned to a caregiver. Always remember, secondary triage is important. Expectant patients may move into a red category and reds may move to black. Likewise with other triage patients. Again, if the patient is breathing, next assess the respiratory rate. If the respiratory rate is less than 15 breaths per minute or greater than 45 breaths per minute, the patient is tagged red or immediate and assigned to a caregiver. If the respiratory rate is between 15 and 45 breaths per minute, assess the pulse of the least injured limb. If there is not a palpable pulse, then the patient is tagged red or immediate and assigned to a caregiver. Finally, the last decision point in Jumpstart Triage is the AVPU scale used to assess mental status. A for alert, V for responsiveness to verbal commands, P for responsiveness to pain, and U for unresponsiveness. If the patient is responsive to pain but posturing, mark them red or immediate and assign them to a caregiver. If the patient is alert and responsive to verbal commands or appropriately responsive to pain and not posturing, then mark them as yellow and they can have delayed treatment. This is the combined START and Jumpstart Triage algorithm.
Now we will discuss the intricacies of decontamination of children. Similar to triage, victims may be contaminated if they are not brought to the hospital by EMS. Please view the module on non-traumatic causes of pediatric surge for information regarding the types of chemical and biological contamination that may present to your facility. Remember the purposes of decontamination. Prevent the contaminant from causing poisoning of the patient, prevent contamination of providers, and prevent contamination of the facility. Always protect yourself first from contamination. You must also protect the patient from further contamination while treating them for exposure to a toxin. When presented with contaminated patients, you first need to discover what the contaminant is so you can properly select the type of decontamination you need to do. Often, over 90% of contaminants can be removed with a dry decontamination process. You will also need to determine the type of personal protective equipment, or PPE, you will need for that contaminant. Remember, children may be very scared of providers dressed in PPEs, and calming them will be key. It is very scary when you're approached by a rescuer in PPE. Remember to smile and to talk to the child as you take them through the process of decontamination. Use the triage and decontamination tags to help identify and keep track of the children. The tags also have waterproof wristbands that will help with identification and keeping personal property together. Try to keep families together so they can help each other disrobe and shower. When there is a large number of patients of different ages, group them by sex and age so it will be easier to manage. Since you will need to move more slowly with young children and assist them in disrobing and showering, realize that this will take more time. Estimate the age of patients by making visual assessment and group them by preschool, school age, and special needs. Infants, toddlers, and children in wheelchairs and those with behavioral needs will need one-to-one care. Infants and toddlers should be carried in plastic clothes hampers or placed on shower gurneys to ease movement through the decon area. Most of these children will need one-to-one attention. Older children will require less supervision, and older age groups can assist the younger children if needed. Non-ambulatory children in wheelchairs or those with special health care needs should be placed on shower gurneys and secured with restraints for decontamination. In conclusion, triage and decontamination of children is achievable. Add JUMP to the START triage and you will save more children. Be prepared to take time to explain to children the decon process, and remember to keep them warm during and after the decontamination process is done. Remember, do no harm.
Thank you for watching this presentation. We encourage you to explore the Pediatric Surge website for more information on topics pertinent to pediatric surge in the state of Minnesota.